Bismillahirrahmanirrahim. Hello everybody, I'm Dr.Mervat Gabal, Professor of Internal Medicine and Rheumatology in Shams University. Today, I will talk to you not as Professor of Internal Medicine and Rheumatology, but as sonographer. Yes, sonographer. During my work in sonography unit that belongs to Rheumatology Department in Shams University Hospital, I met some obstacles I want to share with you. As you all know, in musculoskeletal ultrasound, to take good image is an art. To interpret it is a science. And these science include anatomy, sonoanatomy, and nopology. Nopology means science of machine setting. Also, to understand report by physician or clinician, there must be common language. Also, as you all know, ultrasound image are the final result of multiple reflection process, machine technical capabilities, and knowledge of the performing physician. Any deviation from this will result in pitfalls. To avoid this, I want to talk to you today. So, my target audience are clinicians and beginners in musculoskeletal ultrasound, and the aim is to establish sonographer-clinician similar ultrasound orientation that facilitates sonographer role and help physician to properly interpret report of musculoskeletal ultrasound and consequently to take proper management decision. The first topic to be highlighted today is related to synovitis. Synovitis means either the presence of synovial effusion or synovial hypertrophy. According to UMRAC definition 2005, synovial effusion means presence of intra-articular hypoechoic or anechoic material that's compressible, displaceable, and never exhibit Doppler signal, while synovial hypertrophy means the presence of intra-articular tissue, which is hypoechoic, fully compressible, never displaceable, and may exhibit Doppler signal. Whether by grayscale synovitis or power Doppler synovitis, they are graded from 1 to 3. Now, what is the problem with synovitis? The problem is here. Tenkat et al. In 2013 stated that B-mode synovitis grade 1 can be detected in a significant percentage of healthy people, and at least for diagnostic purpose, its use is debatable. One of you will say that if there is positive Doppler signal in the joint, it will be pathologic synovitis. No, this is not always like that. As Terzlev et al. In 2005 stated that although the presence of intra-articular Doppler signal is associated with pathology, it can be detected in healthy people. Moreover, Padovano et al. In 2015 studied the prevalence of ultrasound synovial inflammatory findings and erosion in healthy subjects. They performed ultrasound of dorsal surface of 32 joints, 10 metacarbophalangeal, 10 proximal interphalangeal, and 10 metatarsophalangeal, and 2 rest joints. This ultrasound was performed in 207 healthy subjects without joint symptoms. The results were like that. Ultrasound findings were detected in 9% of total joints, mostly in feet, especially in first metatarsophalangeal joint. Regarding detailed results, about 52% of subjects had synovial effusion alone, 13% had synovial hypertrophy alone, 5% of them with positive Doppler signal, and 8% without positive Doppler signal. 35% of subjects had both synovial effusion and synovial hypertrophy. In general, synovial effusion was the most frequently detected finding, followed by synovial hypertrophy. The most important finding is that severity was mild, means grade 1 in average, whatever the finding recorded. This means synovial hypertrophy, synovial effusion, or power Doppler signal, the severity was mild, only grade 1. This means that Grade 1 synovitis, whether synovial effusion, synovial hypertrophy, or power Doppler are not valid for diagnostic purpose for pathologic synovitis. Now, how can we diagnose pathologic synovitis, especially rheumatoid arthritis? Minute et al. In 2011 stated that ultrasound criteria for diagnosis of rheumatoid arthritis suggested at least 2 joints showing at least grade 2 or 3 P-mode synovitis or 2 cases of bone erosion. Now, forget about bone erosion. While Sincere et al. In 2011 stated that a power Doppler score of 2 or more was highly specific for rheumatoid arthritis. Also, Salavi et al. In 2010 stated that the positivity of power Doppler in more than 3 joints increased significantly the risk of progression to rheumatoid arthritis. Again, at least 2 joints with at least grade 2 grayscale synovitis, at least more than 3 joints with at least 2 second grade or grade 2 power Doppler synovitis are valid for diagnosis of rheumatoid arthritis. The second topic to be highlighted today is related to bone erosion. And according to Omrak definition 2005, erosion is presence of intra-articular discontinuity of bone cortex seen in 2 perpendicular planes. There are many semi-quantitative scoring systems to grade bone erosion. One of them is that of Skudlarik et al. 2003, but this is not well accepted because they describe grade 1 erosion as having bone cortex irregularity in absence of bone defect, which is against the definition. Better than this is that of Wakefield et al. In 2000. They described bone erosion as being small if less than 2 mm, moderate if between 2 to 4 mm, and large if the size is more than 4 mm. Also, Somir et al. In 2006 scored bone erosion from 0 to 3. Please remember score 2. Please remember score 2. Now, what is the problem with bone erosion? The problem is here. At rest, ultrasound evaluation of bone erosion is difficult because of irregularities of bone margin, several nutrition channels, inadequate acoustic window for visualization, stated by Skudlarik et al. In 2003. At the same time, humeral head erosions can be seen in significant number of healthy people, as stated by Wakefield et al. In 2000. What a mess! Now, how can we diagnose pathologic erosion, consequently erosive arthritis, especially rheumatoid arthritis, which is a prototype of erosive arthritis? The answer is here. In 2014, authors studied bone erosion in rheumatoid arthritis. They performed joint ultrasound in patients with early rheumatoid arthritis in comparison with long-standing rheumatoid arthritis, other erosive disease, and healthy controls. The results were like that. At least one ultrasound erosion was found in 66.7% of patients with early rheumatoid arthritis, and in 33% of them it was found in fifth metatarsal head. Moreover, if the second and fifth metacarpal heads and fifth metatarsal head were scanned, an erosive disease could be found in 60% of early rheumatoid arthritis patients. This means that in early rheumatoid arthritis disease, if we are searching for bone erosion to detect erosive arthritis, the specific sites will be the second and fifth metacarpal heads and the fifth metatarsal head. Zayat in 2015 confirmed that. He studied the specificity of ultrasound-detected bone erosion for rheumatoid arthritis and concluded that erosions with semi-quantitative score 2 or more in 4 target sites, these target sites are Second and fifth metacarpophalangeal, fifth metatarsophalangeal joints, and distal ulna were highly specific for rheumatoid arthritis with specificity 97.9% and sensitivity 41.4%. And the most important is that erosions of any size in fifth metatarsophalangeal joint were both specific and sensitive for rheumatoid arthritis. Please remember, for detection of erosive disease, especially rheumatoid arthritis, search for bone erosions in 4 target sites: second and fifth metacarpophalangeal, fifth metatarsophalangeal, and distal ulna, and this erosion must be of a score 2 or more. This is an example of bone erosion in metacarpal head. It is pathologic erosion as its size is more than 2 millimeters. The third topic to be highlighted today is related to incisions. As you know, incisions mean the connective tissue junction where ligaments and tendons attach to bone. Also, as you know, there are 2 types of incisions: fibrous incisions and fibrocartilaginous incisions. In fibrous incisions, the ligament or tendon attach directly to the bone, while in fibrocartilaginous incisions, there are transition zones. As you see, these transition zones start by tendon proper with longitudinal fibroblast, then zone of fibrocartilage with predominant chondrocytes, followed by abrupt transition to the zone of mineralized fibrocartilage, which is the blue line. Incisopathy in general means the presence of any pathology affecting incisions. This could be degenerative, traumatic, metabolic, or inflammatory. And inflammatory incisopathy is known as incisitis, and this is the hallmark pathology that helps us to diagnose seronegative spondyloarthropathy or axial SpA. By ultrasonography, definition of incisopathy according to Wakefield et al. In 2005 is presence of abnormal hypoechoic and/or thick tendon at its bony attachment seen in 2 perpendicular planes, with or without posterior Doppler signal, with or without bony changes. These bony changes may be irregularities, erosions, or incisophytes. Now, what is the problem with incisopathy? The problem is that incisopathy is not only related to axial SpA. In 2005, Zhang et al. Studied tendons and incisional site by ultrasound in upper limb and lower limb in rheumatoid arthritis patients in comparison to spondyloarthropathy and healthy controls. Their results were like that. There was no statistically significant difference between rheumatoid arthritis and spondyloarthropathy regarding frequency of tendon affection and incisopathy. And the common site of incisopathy in both groups of patients were in proximal and distal patellar tendon attachment and in Achilles tendon attachment. On the other hand, the non-specific plantar fasciitis was detected in significant percentage of healthy control. Also, rheumatoid arthritis differed from healthy control in having high percentage of tendon affection and incisopathy. Now, as sonographer, how can we differentiate between incisopathy and incisitis? According to Falsity et al. In 2009, they stated that Bauer Doppler ultrasound has been proved to be useful for differentiating mechanical or degenerative and inflammatory incisopathy and for monitoring the efficacy of therapy. More accurate is that reported in Euler book for musculoskeletal ultrasound by Lagnuco et al. In 2016, they stated that positive Doppler signal at ligament-bone interface are more specific for axial SpA. Please remember, positive Doppler signal at ligament-bone interface are more specific for axial SPA. This is an example of encephalopathy with common extensor tendon pathology. It appears thick, hypoechoic, however, not associated with bone irregularity. And here, the same case of common extensor tendon encephalopathy, but with positive Doppler signal. This is the non-specific plantar fasciitis in transverse and in longitudinal ultrasound image. It appears thick, hypoechoic with localized hypoechoic defect, which means presence of partial tear. And this is an X-ray image of the characteristic associating calcaneal spur. By the way, calcaneal spur does not arise at the site of attachment of plantar fascia to calcaneum. However, it arises at the site of attachment of the overlying muscle, that's flexor digitorum brevis, with calcaneum, and its protrusion downward into the plantar fascia results in its irritation and inflammation. This is another example of encephalopathy of Achilles tendon with thick, hypoechoic distal attachment of Achilles tendon, again no bone irregularity. The first topic to be highlighted today is related to wrist joint. And the question is that, is the wrist a joint? Anatomically, wrist is variously defined as the carpus, radiocarpal joint, and the anatomical region surrounding the carpus. As you see, here in the wrist joint, there are 3 joints. 2 of them are related to the wrist joint, and 1 of them is separate from them. The first one is the radiocarpal joint between distal end of radius and the first row of carpal bone. And the second one is the mid-carpal joints. This mid-carpal joint is between carpal bone and extending till the proximal end of metacarpal. The third one is the distal radioulnar joint. It is not part of wrist joints. It is separated from radiocarpal joint by the articular disc of triangular fibrocartilage complex. By the way, there is no ulnar triquetral articulation. Ulna comes in contact with triquetrum only during lateral abduction. Why I wanted to emphasize that? Just to be considered by both clinician and sonographer when a patient is referred for musculoskeletal ultrasound of wrist joint for aspiration or injection. I want to emphasize that in wrist region there are 3 joints. These joints are mainly radiocarpal joint, which is the wrist proper, the mid-carpal joint, which extends to metacarpal, proximal metacarpal bone, and the distal radioulnar joint separated from wrist joint by articular disc. The 5th topic to be highlighted today is related to median nerve neuropathy. As you know, median nerve neuropathy may be focal median neuropathy, and the commonest site of entrapment of median nerve is at rest under flexor retinaculum. But median nerve neuropathy may be part of peripheral polyneuropathy. Both conditions are associated in up to 1/3 of cases. To remember causes of carpal tunnel syndrome or focal median neuropathy at rest, there is an easy mnemonic. That's median trap. M for myxedema, E for edema, D for diabetes, I for idiopathic, A for acromegaly, N for neoplasm, T for trauma, R for rheumatoid arthritis, A for amyloidosis, and P for pregnancy. As you know, median nerve is formed by contribution from lateral and medial cords brachial plexus. It passes in the arm without giving any branches. Then it enters the forearm between the 2 heads of pronator teres, then passes under the arch of flexor digitorum superficialis. After coming out pronator teres, it gives its main branch, which is the anterior interosseous nerve, which is pure motor nerve. It supplies only 3 muscles. These muscles are flexor pollicis longus, lateral half of flexor digitorum profundus, and pronator quadratus. Then it comes from under the flexor digitorum superficialis and enter below flexor retinaculum at the rest into carpal tunnel. Before entering the carpal tunnel, it gives its palmar cutaneous branch, which pass overlying the flexor retinaculum to supply senar muscle. Consequently, please, before referring the patient to do musculoskeletal ultrasound with or without intervention as carpal tunnel syndrome, please, dear clinician, make sure it's carpal tunnel syndrome. This could be achieved by ensuring that the anterior interosseous nerve and palmar cutaneous branch of median nerve are intact. Testing for the function of anterior interosseous nerve is through asking the patient to do OK sign or O sign. This is the function of flexor pollicis longus and flexor digitorum profundus. So ask the patient to do OK sign or O sign by his index and thumb. If this is intact and perfect, this indicates intact anterior interosseous nerve and exclude injury of median nerve in proximal forearm. Also, to ensure that this is carpal tunnel syndrome and the only site of entrapment of median nerve occurred under flexor retinaculum, exclude injury of palmar cutaneous branch, which arises from median nerve before its entry below flexor retinaculum. This could be tested by testing for sensation over senar eminence. There are many provocative tests that help to confirm presence of carpal tunnel syndrome, like positive Tinel sign, positive Fallen sign. However, these tests have low validity. The gold standard for diagnosis of carpal tunnel syndrome is by asking for electrodiagnostic studies, including nerve conduction study with or without needle electromyography. In general, dear clinician, you can refer the patient for musculoskeletal ultrasound and ultrasound guided local steroid injection when there is mild carpal tunnel syndrome with intermittent symptoms. Also, local injection may have diagnostic or prognostic role as predictor of response to surgical release. The sixth topic to be highlighted today is related to knee ultrasonography. Very commonly, the clinician refer a patient to do musculoskeletal ultrasound for knee joint if there is knee swelling with clinical effusion. When effusion is like that, appear anechoic and of moderate to large amount, it is known as simple effusion. And if it appears turbid, it may be due to infection, may be due to crystal arthropathy, or may be due to heme arthrosis. There is no problem here. Where is the problem? The problem is here when there is mild effusion associated with huge synovial hypertrophy, which may exhibit Doppler signal or may be inactive synovial hypertrophy. In this condition, this is a difficult case for aspiration, as this hypertrophic synovium may plug the aperture of the syringe or even the cannula, prevent aspiration, and will be severely painful to the patient. So, dear clinician, don't be astonished if you refer a patient with knee swelling for aspiration in presence of huge synovial hypertrophy and the sonographer failed to aspirate this joint. And dear beginner sonographer, don't be disappointed if you fail to aspirate such case. The last point to be highlighted today is related to joint interventional procedure. There are many contraindications for intra-articular injection or aspiration. One of them is the bleeding tendency, especially if platelet count is less than 50,000 or there is coagulopathy, whether caused by disease process or by anticoagulant therapy. Dear clinician, don't refer patient for intra-articular injection or aspiration guided by sonography, except if after correction of thrombocytopenia to be higher than 50,000 and after correction of coagulopathy, whether due to disease process or due to anticoagulant therapy, to avoid complicating hematolosis with subsequent infection or joint damage. Now, I want you to take home message. Ultrasound language facilitates sonographer rule and physician interpretation of reports. Consequently, proper management decision will be taken. Thank you for your time. See you soon in another part with new highlights.